afternoon. My name is Dr. Wong Teck Wee. I'm a consultant cardiologist. Today, I have an old friend, Dr. Ravi. So Dr. Ravi, I knew him in year 2007. At that time, we worked in Hospital Kuala Lumpur in Ward 18. And I just came back from Singapore, and he asked me what course that he should be taking, what specialty that he should be involved in. So I told him oncology is a good field for him, and he should go to Singapore to be trained. And since then, he has been staying in Singapore and not coming back to Malaysia. So it's lots of our talent. So Associate Professor Ravindran is the Deputy Chair and the Senior Consultant in the Division of Medical Oncology of the National Cancer Center in Singapore. He is also the Associate Professor at Duke-NUS Medical School, and he's actively involved in graduate medical education. His research interests include genitourinary oncology and also geriatric oncology. He has published in well-known peer-reviewed journals, including Journal of Clinical Oncology and Lancet Oncology. He is the author of several textbook chapters in geriatric oncology and published more than 180 peer-reviewed papers. He is currently the past president of the Singapore Society of Oncology and the Singapore Geriatric Oncology Society. He is also the past president of the International Society of Geriatric Oncology. He is also the vice chairman of the Singapore Cancer Society now and the past council member of the European Society of Medical Oncology, the ESMO. So with that, I invite Dr. Ravi to speak on oncology that is practical for general practitioner in Malaysia. Prof. Ravi, the stage yours.
Thank you, Dr. Wong, for those kind words. And it's true, Dr. Wong, first came back to Singapore 2007, and he was the one amongst two of them. There was another Dr. Lok as well, who also came back with him. And both of them one day sat me down and said, there are a few fields that are, progressing very rapidly. You may want to consider training in them. And through their help, I got connected with some of the oncologists in Singapore, and the rest is, as they say, history. But yes, I have not come back to Malaysia since. But I do come back very often, and I do give talks and conduct training for Malaysian oncologists. So I'm basically a medical oncologist. So in Singapore, oncology is divided into two groups. One is a medical oncologist like myself. So we give systemic therapy, so chemo, targeted therapy, immunotherapy, that comes under our domain. And my colleagues in radiation oncology will deliver radiotherapy. So it's a separate field. In Malaysia, it is a bit different, as both the chemotherapy, the systemic therapy, and radiation is delivered by the clinical oncologist, which makes a lot of sense in Malaysia because Malaysia is still very short of oncology specialists. So that's the difference. So later on, while I may describe a bit about what radiotherapy is, the disclaimer is I am not an expert in that area. We only train in medical therapy. So today's talk, I'm aware that many of you are family physicians or generalists, or maybe even specialists in other specialties like cardiology or gastro. And in that sense, my goal is to really talk to you about cancer as a whole and what some of the treatment options are. And also, if you're a family physician, what role you can play in helping cancer patients in their journey with cancer. So that is basically what I'm going to talk to you in the next 20 minutes. Now, cancer has come out a lot in the press. I'm sure even in Malaysia, you read a lot about it. And one of the reasons why, 16 years ago, I embarked on the journey, apart from Dr. Wong talking to me about it, is because my mother herself was then diagnosed in 2007 with breast cancer. She has passed on roughly about 6 years ago in 2017. So she survived about 10 years with the cancer. Initially was localized. And when I was taking her to appointments, at the time it was at University Malaya Medical Center, I read up more about oncology because I was at a crossroad. I was deciding what to do. I thought maybe gastro because, you know, there's procedure and all that. So I started a bit of training in gastro at that point in time. But as I read more about oncology, I realized it is really a field where there's much to be done. So patients who are diagnosed with terminal cancers actually do very poorly. So as such, it provided us who were interested in the field opportunity to do research, to try to push those boundaries, you know, improve their survival, but at the same time, making sure their quality of life is preserved, right? So this is the tough balance that all of us face in medicine in general, not just in oncology. But in oncology, because the drugs are so toxic, it is something we need to think about before we prescribe any form of treatment, because the benefit must outweigh the cost. The prolongation of life must come with good or decent quality of life, because otherwise, no point prolonging life if what we are doing is just prolonging suffering, right? So normal body cells, they divide and die normally. Cancer cells don't. And there's some reasons for this. There's usually a mutation in the cancer cell DNA or the normal cell DNA that transforms it into a cancer cell. And that is unfortunately one of the issues with regards to the disease, because there are a number of pathways that can get mutated. And unfortunately, we don't have drugs that can target all the pathways. And if we did, that will be damaging to normal cells as well. So there are many, many known cancers. And I think all of you will be familiar with this, either because you have treated some of these patients or you have sent some of these patients to the oncologist. You may have diagnosed them firsthand, or you may even have family and friends who have these diseases as well. So it's a very homogeneous disease. Now, cancer is called the emperor of all diseases and emperor of all maladies. The reason for this is because up to this point, number one, it's broadly deadly unless you find it very, very early in the early stages. And the reality is, even if you do, there's always chance of recurrence. So we've not really found a panacea, cure that can really, transform the way these patients survive. While we say that, yes, if you diagnose it early, many of these patients may live a near normal life. But depending on the type of cancer, some cancers are more aggressive than others. They may ultimately still experience a relapse, and that's the fear. That's what causes anxiety in all cancer patients. Am I going to get a relapse, and what's going to happen after that? So this is an interesting read. So Siddhartha Mukherjee is an American Indian oncologist. So he was trained in the Dana-Farber Cancer Institute. So it's a very bright, doctor who's now, I think, his late 40s, may have touched 50, and he wrote this New York Times bestseller about more than a decade ago. So about 10 years ago, he wrote this called The Emperor of All Maladies. Why did it become a bestseller? It's basically a very easy to read book on the biography of cancer. So people write biographies about, many, many things, right? Including autobiographies when they talk about themselves or people. But in this case, he talks about how cancer was first discovered. So this goes back centuries ago, and how really mankind didn't really make much progress until the last 50 years. So much of that progress first started with blood cancers in his hospital, where he trained in Dana-Farber Cancer Institute. And then, of course, with blood cancers being treated, solid cancers slowly came into the picture. And I'll explain to you why cancers are becoming more common now, because I think you hear a lot of your family, friends, all talking about it because somebody has experienced it, and you'll be wondering why 20, 30 years ago you didn't hear it so frequently. So I'll provide a reason for that in a short while, and that's related as well to the cancer demographics. So firstly, the world is aging. Now, this is something I think comes out in the press a lot. And Dr. Wong was a past president of the Malaysian Healthy Aging Society. So that society was founded on one of the basis for the founding of the society was because Malaysia is aging as well. So the aged population in most developed countries is nearly 1 in 5. So in Singapore now, 21% of our population here is age 65 and above, 21%. In the next couple of years, it will be 1 in 4. They estimate by 2028 or to 2030, it will be 1 in 4. And Malaysia is not far behind. It's, I think, more than 10% now, and it's slowly going to reach there. So this is because we've got better medical care and so on. I think you all are familiar with that. But what I want to highlight here is most of the growth is going to occur in developing countries. So you can see here in Asia, there's going to be a huge jump of nearly 226%, especially in Central and Southeast Asia, 176% increase between 2019 and 2050. That's going to be more than a doubling of the aged population. So we're all going to be dealing with the silver tsunami. Now, you're wondering what's the relationship between that and cancer. So first thing I want to highlight is these are the estimated number of new cases of cancer from 2020 to 2040, the estimated growth. The biggest growth is going to be in Asia again, right? Because India and China are the two most populous countries, and they are aging. So with aging, cancer increases as well. So that's one thing I wanted to highlight. As you can see here, a lot of growth is also going to happen in other developed parts of the world, including Africa and Latin America. Now, this is data from the US. So most of cancer occurs in patients 60 years and above. So obviously, this is the demographics for cancer in a developed country. And you can see here, if you add in males, patients age 60 to 69 plus 70 to 79 onwards and 80 plus, if you add these numbers here, it accounts for more than 60% of cancer patients, right? So cancer is a disease of aging. Even in females, if you add 16 and 22 and 26, it's also there. Majority of cancer patients are older. So one of the reasons why 20, 30 years ago, we didn't hear as much about cancer was because our average lifespan was shorter. So people were not living to their 70s, 80s, and 90s. And usually they succumb to cardiovascular illnesses. So usually it's a heart attack or a stroke and so on. But now if you live long enough, and thanks to the good care that Dr. Wong and cardiologists provide for you, you unfortunately will live long enough to get cancer. And there are many reasons why we get it, and I'll go through them in a short while. But that is why now you hear cancer occurring more frequently, because we are aging as a population. Now in Singapore, the top 5 cancers listed here, as you can see, there's a sharp rise in certain cancers like breast and prostate. Prostate is number 2 in males, breast is number 1 in females. You can see there. The highest in males is still colorectal. And then lung cancer has dropped a lot. So policy is really important because cigarettes have become very expensive and there's a lot of campaigns. So you see lung cancer dropping, colorectal is very high. And number 3 is prostate cancer. And prostate cancer is mainly in older patients, right? So you can see how aging is transforming the types of cancers that we see. Now in females in Singapore, breast is number 1, colorectal is number 2, you see here. And then number 3 is the green line there. It's lung, but uterus cancer is slowly overtaking. So again, lung cancer is dropping in general. So aging population, we have a sedentary lifestyle. Obesity is linked to cancer as well. However, because we have better diagnostics, we got better screening programs, we got better supportive and survivorship care, there are more survivors. So while there are more cancers, there are also more survivors. And this has implications to the role a family physician can play in jointly taking care of these survivors. So I'll talk to you about that towards the end. Now, disease burden-wise, cancer accounts for 15% of all diseases, but in terms of mortality, cancer accounts for 30% of mortality in Singapore. So 1 in 3 people in Singapore die from cancer, 1 in 3, because it's a fatal disease. You see from a lot of diseases here, you can actually get cured, you can get treated, or it may become chronic. Cancer, yes, it's slowly becoming chronic, but whilst only 15% of the population has cancer, 30% of death is because of cancer. Now, is the situation going to improve? We don't know, because there are a lot of things in the environment that's probably causing it. These are non-modifiable factors. We can't control the genes we inherit, and current thinking is about 1 in 5 or 10 to 20% of cancers are hereditary, and we're just learning more about it. But 80% of cancers are due to somatic mutations, mutations that occur during our lifetime. So it could be due to chemicals. Slowly, we're identifying these chemicals. I think some of you would have read about the WHO warning on aspartame, which is the artificial sweetener that you use in your Diet Coke, your Coke Zero. That is cancer causing. However, the same warning also had some data behind it, which showed that you need to be drinking like 30, 40 cans of Diet Coke a day to have that increased risk of cancer. So one Diet Coke can a day probably may not increase it so much. But the reality is that chemical itself is carcinogenic. It does cause cancer. So a lot of things in our food, in our environment, have chemicals in them that may be causing cancer, and we're slowly learning about it. Now, also, about 10 to 20% of cancers are caused by viruses and bacteria. Many of you would have heard of HPV, human papilloma virus, which causes cervical cancer. You would have heard of EBV. EBV causes nasopharyngeal cancer. So that's a problem as well. Radiation causes cancer, and there's definitely background radiation depending on where you stay, how close you stay to certain places that emit radiation. If you travel a lot, there's also a risk because there's radiation from the environment that can affect you when you're in a plane. However, you need lots of it in order to get cancer. Now, diet and hormones also play a role, and we're slowly learning what those things can do to you. Now, other causes include tobacco smoking. So these are modifiable causes, which I'll again go through a little bit more in a short while. Obesity is a cause, and infections are cause, which are modifiable, right? So that's why there's HPV vaccination for females especially, and in some developed countries, males get HPV vaccination. Now, can we prevent it? Yes, we can, because there are some modifiable things. Now, diet, definitely. So there are certain things in our diet. I mentioned, avoiding artificial sweeteners, which now has been proven to be cancer causing. There are certain preservatives that may cause cancer as well. Smoking, definitely a major cause of cancer. There's so many chemicals in it. You're at risk for multiple cancers, head and neck, lung, even bladder cancer is increased because of smoking. Alcohol, definitely, this can cause liver impairment, liver cirrhosis, and long-term damage can lead to hepatomas and hepatocellular carcinomas. Lack of exercise is a problem. It correlates with obesity, which increases the risk of cancer as well. And too much sun exposure, not a problem for many of us in Asia because we hate the sun. It's very hot out there, so we don't really go out a lot. But in other countries like Australia, it's a big problem where skin cancers are a major issue. So how do we fight them? What do we have in our arsenal of treatment options? What can we use? Some of these things you're very familiar with, right? So firstly, we have surgery. Now, if you're diagnosed early, surgery would cure you. Is that true? Yes, the answer is probably true to a great extent. If it's stage 1 of any cancer, surgically removing it actually gives you the best chance of cure. So surgery is number 1 on the list. If you can remove, that's the best. Now, however, there are circumstances where surgery alone is not enough, even in early stage. So we give what's called adjuvant chemotherapy. Adjuvant chemotherapy basically means giving chemotherapy after surgery. Why do we do that? We do that to kill micrometastasis, small amounts of cancer cells that may be circulating in your bloodstream, may be hiding in your lymph nodes or in other organs, and chemotherapy after surgery can help reduce the risk of relapse. However, chemotherapy's biggest role is in advanced cancer, stage 4 or metastatic cancer. They all mean the same thing. It means terminal cancer, and chemotherapy can kill a lot of the cells, but it only buys you time. After a while, cancer cells learn how to mutate, fight the chemotherapy, and proliferate. Now, radiotherapy. Radiotherapy has 2 roles. One, in the curative setting. So, for example, in nasopharyngeal carcinoma, we give radiotherapy to actually cure the cancer, right? It is the primary treatment. We don't do surgery because it's challenging in that particular area. It's very morbid. Radiotherapy actually does an excellent job and can provide cure as well. Similarly, in prostate cancer, radiotherapy is an alternative to surgery. However, radiotherapy is also used in the terminal stages. So for example, if you have lung cancer that's spread to the bone and your bone hurts a lot, you can send the patient for palliative radiotherapy. The goal for that is actually to kill the cancer cells there such that it will reduce the pain. However, one thing to note about radiotherapy is the tissue in our body have a limit at which it can tolerate radiation. You exceed the limit and the tissue actually gets permanently damaged, which can cause, when it's normal tissue, it can cause the patient a lot of harm. Immunotherapy is something new. I'll explain immunotherapy in a short while. Basically, it's stimulating your own immune system to kill the cancer cells. However, all these therapies come with its own list of side effects. There's something called molecular targeted therapy. Now, what we have discovered through science is, as you know, when we can do something called next generation sequencing, we can actually interrogate the tumor cell DNA, and now even the RNA. And when you interrogate the cell DNA, you can identify the mutation that's causing the tumor to grow. These are what we call oncogenic drivers. So, and also called driver mutations. Driver mutations means these are mutations that's driving the growth of cancer. Unfortunately, when we do these kind of molecular tests, we also get a lot of noise. Noise means there are also passenger mutations. These passenger mutations do not actually drive the cancer. So we may get a lot of noise, background noise, which are not really helpful to us. And multimodality therapy. I put MDT there because now cancer care is no more compartmentalized. It's no more about the surgeon alone. It's no more about the medical oncologist alone. It's no more about the pathologist. Everyone should meet together, discuss the case, and come up with the best solution. It's all multimodality therapy now, or multidisciplinary teams involved in multimodality. And from that perspective, I think family physicians or GPs play a big role. Now, on the left-hand side is what you would think about traditional systemic chemotherapy. So these are patients in what we call ambulatory treatment unit. So patients for chemo don't really need to get admitted in the ward at all. I mean, even in Malaysia, Singapore, they're all outpatient treatment. They sit next to the chemo is delivered, and they go back home, there are side effects. But now I think just, for many of you who may not be familiar with the new developments, some of the new chemotherapies actually do not cause hair loss. So sometimes patients, will have their full head of hair and they come to you and you'll be surprised, you'll be wondering, how come this chemotherapy doesn't cause hair loss? So not all chemotherapy causes alopecia. Not all chemotherapy will make them tired and bedridden. Some chemotherapy are actually quite light. In fact, on the right-hand side, I put a picture of chemotherapy pills, right? So now you can actually find chemotherapy that comes in the pill form. These are not targeted therapy. These are not any new kind of special therapy. They're chemotherapy. They just come in a form that can be absorbed by your gut and then transformed into the active drug, which is similar to your chemotherapy. So one example is a drug called Xeloda or capecitabine. So capecitabine is actually a 5-FU, 5-fluorouracil prodrug. So when you swallow these tablets, it goes into your gut, gets absorbed, and be transformed into 5-fluorouracil, which for many years was the mainstay of treatment for many cancers. Everything was 5-FU, right? It was just a drip, you go, get your treatment and leave. Now you can take a tablet form of it, and side effects generally manageable. Some of it may be a bit different from the actual 5-fluorouracil, but if you recall, in colorectal cancer, for example, 5-fluorouracil is given as a chemo pump. So that's very troublesome for patients. They need to go back home 3 days and then come back and off the pump. Now they have a pump. Those days they need to be admitted in the hospital where they are putting themselves open to a lot of toxicities and so on. So chemotherapy has again progressed quite a bit, but we have moved on to the era of targeted therapy now. So on the left-hand side is the cell division. So many of you are familiar with this. This is, how cells divide. And when there's an aberration or abnormality in the cell DNA, there's no control over cell division. So it affects a process called apoptosis. You all are familiar. That's cell death. Now, what happens is in cancer proliferation or oncogenesis, cell death is actually impeded. The processes all go haywire, cells don't die, and it grows into a tumor. Now, chemotherapy works on the cell cycle. So it finds ways to actually, you see alkylating agents or anti-metabolites, they all work on the cell cycle. By preventing cell division, it helps the cell to apoptosize and die. Now, on the right-hand side is targeted therapy. So targeted therapy looks at specific pathways on the cell. Some may be on the cell surface. Most of it are inside the tumor cell. And what it does is it blocks oncogenic pathways. That means pathways that stimulate cell proliferation or growth. You take this drug, it blocks that pathway, and the cell cannot proliferate. It will then involute or die, right? So there are many, many pathways. So some of you would have heard these drugs. I'm sorry, I can't simplify this any further, but this kind of covers many of the targeted therapies. So on the left-hand side to the right-hand side, these are various targets, right? Some on the top is extracellular, and on the bottom, after those, below the cell surface, you can see the cytoplasm and the nucleus. So these pathways target different targets. For example, you may have heard something in the middle called EGFR or HER1. EGFR alterations or mutations occur a lot in lung cancer. So we have a number of targets like erlotinib that targets the EGFR pathway, specifically for those with exon 19 or 21 mutations. That means within that particular gene, these exons are mutated such that erlotinib will work, and then it cuts off the pathway from causing cells to proliferate. As you can see at the bottom, what causes cancer is proliferation, survival, metastasis, and angiogenesis. Angiogenesis is needed for blood supply to supply the cancer cell. So that is something you may be familiar with, right? EGFR in lung or HER2 in breast. You see lapatinib or trastuzumab blocks it from the extracellular domain, from the outside. Lapatinib from the intracellular domain, right? So there are many, many targets here and many, many drugs. Some you may have heard your patients talk about, and this is exactly how it works. Now, you'll be thinking, if it works like this, then why won't cell death just continue, and why can't we kill all the cells? Unfortunately, as you can see there, that RAS, PI3 kinase pathway, MEK, ERK, mTOR, there's so many complex pathways. There's chromatin remodeling gene pathways. There's so many of these pathways that are present. So when you block one, another gets activated. So what becomes, what was a passenger, driver or mutation, now becomes a driver mutation, which then would cause the cancer. And we need to think of combination therapy, right? So I'm going to move from systemic and targeted therapy to radiotherapy. On the left-hand side is your traditional linear accelerator radiotherapy machine. So this is present in many centers in Malaysia, Singapore. It's our standard radiotherapy, which now is quite targeted. The newer machines are better. Now, the difference between older and newer machines is how targeted they are, hence reducing collateral damage. Now, what we know for a fact is, especially for humans, when we target specific organs like the lung, we have to breathe. Even if you hold your breath, how long can you hold? So there's some movement. And with that, some of the good cells get damaged as well, as targeted as can be. On the right-hand side is a proton therapy machine. So we just got our first one at the National Cancer Center with 4 gantries. It's one of the biggest in Asia. And with that, we are able to deliver even more targeted therapy. So the side effects are less now. And that's one of the newest technologies. It takes up a huge space in our center, 3 floors of our building. So let's go on to immunotherapy. Now, immunotherapy has come in the last decade, about 10 years now. Now, what does it mean? There are various types of immunotherapy. So you may have heard of cell-based therapy. And this, unfortunately, has been misused sometimes by various entities in different countries. A lot of people come and say, you know what, I can do this for you, I've got this product from China or somewhere where I take your blood and then I will treat it and then I'll insert it back to you. So yeah, conceptually, that's what cell-based therapies are. Unfortunately, those may not be producing the right product. What we know right now, in fact, one of the best technologies are with CAR T cells. And that's pretty expensive. Again, the concept is similar. It's a cell-based therapy that is specific to the individual, right? And many of it use CRISPR or gene editing technology, right? So that's something very new in the market as well. But this all takes billions of dollars of research. Hence, the cost of giving these therapies are very expensive, nearly $1 million in Singapore right now. So when someone offers something for a few thousand, really you should think about whether it's truly immunotherapy or not. You need to investigate before jumping into it. Now, more commonly, what you see commercially available is right at the bottom. They call them immune checkpoint blockade therapy. Now, how that works, I tried to simplify it with a cartoon here. You can see the tumor cell on your right at the bottom. And you can see tumor macrophage, dendritic cells, and T cells. Now, I want you to focus on the rightmost side of the base, right? So usually activated T cells, without any PD-1 on it, it can actually target your tumor cell because your tumor cell is abnormal to the body. Unfortunately, there are mechanisms there. They call them immune checkpoints. These are these checkpoints called programmed cell death 1 or PD-1, or their ligand. The ligand is on the tumor cell. PD-1 is on the T cell. So when they combine, okay, you can actually prevent the tumor cell from dying, right? So when the PD-1 joins the PD-L1, it prevents it from dying. Now, if you have an immune checkpoint blockade, like an anti-PD-1 antibody, so it blocks the PD-1, or you can use a PD-L1 that blocks it on the tumor cell, then this two will not join. And if they don't join, the T cell becomes activated and it can kill the cancer cell. So that's how immunotherapy works. And that's the most common immunotherapy that you hear many of our oncologists using right now. There are many names like pembrolizumab, nivolumab, atezolizumab, durvalumab. These are the common ones. Some are PD-1 inhibitors like pembro. Some are PD-L1 inhibitors like atezo. And there are more coming in the market. So many of you know about the COVID vaccine. I think that's well known now. They use mRNA technology. Now, this mRNA technology was developed for cancer. And companies like BioNTech, Pfizer-BioNTech, or Moderna, they were all cancer research companies. They were using mRNA to kill cancer cells. But COVID came and they used that same technology to develop COVID vaccines. And now that they have more money because they sold COVID vaccines, there's an acceleration in the growth in cancer vaccine development. Very soon, in the next year, you'll probably hear of cancer vaccines coming in a big way, and that's the next wave of immunotherapy. It's going to be cancer vaccines killing cancer cells, right? The other things like antibody drug conjugate, bispecific, they're all in development, but immunotherapy is a very big field. What you probably hear about is right at the bottom, which is an immune checkpoint blockade. So there's targeted therapy and there's precision medicine, and there's traditional and precision, right? So traditional medicine is more like blunderbuss. We just throw in, chemicals like chemotherapy. It kills cancer cells, but it kills normal cells. Now, precision medicine is now in many centers, when we know we have a target, we do genetic sequencing of the tumor. So one of the things that's done nowadays quite routinely is next generation sequencing, or NGS. So we take the tumor cell, and in fact, the technology has gone one step ahead. We don't even need the tumor. We can take blood and capture circulating tumor cells that are within the blood. And we sequence those circulating tumor cells. We find the mutation and we give the right treatment to the right mutation. This doesn't mean it's a cure, but at least we are more targeted. So hopefully we can control side effects. Now, side effects are a big deal. I think many of the patients sometimes come to you because they can't get an appointment with the oncologist over the weekend. And they come to the family physician and say, you know what, I'm having all this problem, nausea, vomiting. Many of it you can treat, especially if you can understand how the drug works. You know the drug is the cause. First step, if it's severe, stop the drug, if it's oral drugs. Number two, treat the symptom. Whatever they're feeling, nausea, vomiting, give them the medication. If it's high BP, treat the high blood pressure. Other things, you may need the oncologist to get involved. Now, what has changed is because we have newer drugs like immunotherapy. These immunotherapies, it's a new class used in multiple cancers and generally is well tolerated. But 5 to 10% may experience very severe immune-related adverse events. So our short form for it is IRAE. Now, what happens is you're stimulating the immune system, your own body's immune system, to kill the cancer cells. Now, that can overstimulate. You have active T cells going all over your body. You can have it in your neurological system, pulmonary, hepatic, skin, GI system, renal, and so on. And when you overstimulate, these cells can cause inflammation. So you have, nephritis, hepatitis, you can get psoriasis or dermatitis, so itis, right? We call it panitis. It doesn't mean everyone will get all of this, but some people will get some of this and minority. So compared to chemo, the side effects are better tolerated, but they still can experience this. RT, you have some local side effects you can see there. I have to run through a bit quickly. I think you're familiar with hospice. This is usually, terminal stages. We work with the palliative physicians. Now, the reason I bring about hospice is I'm now going to transition to a bit about how general practitioners can actually help oncologists in treating cancer patients. And I hope this will be useful to you. So many years ago, this is our first director of the cancer center. He's now left us and retired and gone to private practice. He realized that there are going to be more and more cancer survivors. And if they're cancer survivors, they're going to be in the community. And we want our primary care physician or family physicians to be actively involved. So there are a number of studies done that show that GPs have a valuable role in the cancer care trajectories. And sometimes it may not be a GP. It may be a cardiologist, it may be an endocrinologist who's seeing the patient, but they also act like a GP as well. They check the patient's lipids, sugars, do general investigations, which very often, unfortunately, in the oncology clinic, we don't have time. We're so focused on the cancer, we neglect these things. And many patients in the past didn't survive very long. So you may not think a statin is useful and so on. But if a patient is going to survive 5 or 10 years from the cancer, especially now my prostate cancer patients are on average surviving between 5 to 10 years, even with stage 4 disease. So I need to take care of their cholesterol levels. Otherwise, they will now return back to the cycle of dying from cardiovascular disease, and the cancer doesn't become a problem. And that's unfortunately not a good way, right? So many groups have looked at it, and they found that GPs can play a big role. We're talking about Australia. They have done studies in New Zealand, in the UK, and even Malaysia has looked at it in certain angles. There are some publications as well. I think here is a reference from Malaysia Kini, but there's definitely interest in doing so. This is one of my colleagues, Simon. So he saw this, being an important thing more than a decade ago. So he started engaging GPs. So as a center, National Cancer Center, we actually try to engage them to get actively involved. Now, one of the barriers was the fact that GPs felt this was very complex. But what we want GPs assistance with is more of helping us with symptom relief, more of helping us with dealing with chronic medical problems, comorbidities that they experience, and how to integrate that with their cancer care. Because some worry is there going to be drug-drug interaction? How is this going to impact their organ function and things and so on and so forth? So if they are better educated, then they can do this much better. I didn't talk about screening because all of you know about screening. But in Singapore now, we have this program called Screen for Life. So anybody aged more than 50 will get colorectal, breast, and cervical cancer screening. And all this is done at the GP level. So they don't have to come to a cancer center, or it's done by the GPs. And GPs are educated about clinical pathways, where to refer, and how to go about doing this. We call it what we're going to call cancer service line development. Now, survivors prefer to have their needs addressed by the oncologist, but they want their primary care provider to have a role. They go to the oncologist because they fear relapse, or they fear that, if they experience toxicities, the oncologist may know better. But a lot of times they build a rapport with the primary care physician. So a lot of care coordination can be done there. Now, currently, even in Singapore, it's fragmented. So PCP stands for primary care provider, and they're not looped in, right? Some of your patients are seeing an oncologist, but does the oncologist write to you about the cancer care, about the medication? They probably don't. And that's why there's a bit of this fragmentation of care. And ultimately, this is not good because patients suffer, right? Their health behaviors decline. Maybe their oncology part is being treated properly, but they neglect their sugar control, they neglect their blood pressure, their statins, and so on, their cholesterol. And this leads to poorer patient outcome. Now, what we are advocating, and we're going out to the community to talk to GPs, is join our team, join our survivorship team, learn about us. Let's work at treating these patients together. So this is a program that's already been rolled out. One of my colleagues, who is a general practitioner, she's a family physician, runs it, and we have published a bit. A lot of it is for breast cancer, because breast cancer has seen many survivors, especially now with screening. They're being picked up early and they survive for many years. We've done a study on this where there's an intervention group, sees a polyclinic doctor and an oncologist versus those who are cured and are survivors but don't really have regular appointments. And clearly, there's a benefit for the shared care model. They value the presence of an existing regular family physician visit, and there's a care coordinator that coordinates all their care. So ultimately, I think multidisciplinary teams, including the family physician, is probably the way to go forward. You know, there are a lot of things that sometimes in hospital as specialists we neglect. Complementary therapy. All our patients are on complementary therapy. How much do we know about them? And actually, the reality is many of them may be useful. We need to know, we need to understand these things. We cannot ignore and say, oh no, it's bad for you, because patients are going to get it. So we need to be knowledgeable about it as well. WONCA is actually the World Association for Family Physicians, and they have advocated this as well to jointly work with oncologists and provide patients and family as well their support right through survivorship, right to palliative care. So this is the cancer journey. On the left-hand side, you get diagnosed, and sometimes you get relapses. And towards the right-hand side, unfortunately, many cancers relapse and patients experience, death ultimately. But in the process, we can play a big role in easing them, providing them comfort, and enabling them good quality of care. So WONCA actually have a special interest group in this, looking at cancer and palliative care. And how do we integrate this? I think you need to engage the governments, change policy, highlight the role of family physicians, educate family physicians. So we have diploma programs for nurses in cancer, for GPs in cancer care. Find pathways where you work together with them. So last but not least, this is my final slide. Cancer is a global scourge. It's now increasing because we're all growing older. There are many modifiable factors. So family physicians play a critical role in recommending lifestyle changes. There's a lot of advancement in R&D. I went through with you some of them. Family physicians definitely play a critical role in the cancer patient's journey. Please get involved with your oncologist in delivering the best care you can to your patients. I'd like to acknowledge my colleagues, Rose and Ryan, who are part of the survivorship program, and they helped with some of my slides. Okay, now, most importantly, we are Malaysian Healthy Aging Society. So Dr. Wong and his colleagues at MHAS, of which I'm involved as well, will be organizing the ASEAN Conference of Healthy Aging. So this specifically targeted at medical professionals like yourself. So it's a general conference covering many aspects of healthy aging. That's probably the best way to even fight cancer. So healthy aging may be a treatment solution to cancer, right? You age healthily to prevent yourself from getting cancer. Now, this is 30th July to 1st of August, and I hope to see all of you there. I'll be there as well. So will Dr. Wong. This is my contact. If you want to drop me an email, my Twitter is Ravi Kanesvaran. That's our new cancer center, just opened 6 months ago. Yep, I'm open for questions. I'm sorry if I took beyond my time. I apologize.
No problem. Thank you, Prof. Ravi. Regarding this healthy aging and also slowing down aging, it's not just for cancer, it's for many chronic diseases like ischemic heart disease,
Yep.
Diabetes, and high blood pressure. So if you can slow down aging, you can slow down a lot of these chronic diseases.
I fully agree.
Yeah. I have some questions for you. The data in Malaysia and Singapore have shown that there are some racial difference in terms of cancer, and it seems like the Chinese has higher risk of getting cancer compared to Malay and Indian, about maybe 50% higher. So is there a reason for that?
Yeah, so there are reasons. Number one, it's hereditary. So certain cancers that are common in this part of the world, for example, nasopharyngeal carcinoma is very common among Chinese. It's because of the presence of this virus, I told you, EBV, but also there's a genetic predisposition as well amongst Chinese from southern China. So if you have, come down from southern China, your ancestors have come down from there, then you have higher risk of that cancer. There are definitely some mutational changes as well that are hereditary that may increase that risk. Now, the other thing could also be diet. And that's something to explore. What we know is, for example, Japanese, not specifically Chinese, but Japanese who eat a lot of smoked food or grilled, they have high risk of gastric cancer, right? So that's the problem. In, for example, Chinese in Taiwan, they actually use a particular type of traditional medicine that they call it erectocolic acid, which is used in certain beauty products that increases the risk of bladder cancer, upper tract bladder cancer. So they have 4 times higher the rate of upper tract bladder cancer than other parts of the world because of consumption. So there are modifiable environmental factors that maybe can account for it, but there are also genetic factors which we can't help. So if you can't do anything about genetic factors, then get your screening done early. So for example, now there's blood tests that can actually detect your risk of getting nasopharyngeal carcinoma. So in Hong Kong, they have deployed it because they are Southern Chinese there, and they have a high risk of NPC, and they can actually do a blood test to detect their risk of getting nasopharyngeal cancer. So some things are not modifiable or hereditary, and that's why certain races have higher predisposition. Others could be environmental, so you have to pick and choose the kind of food you eat and so on and so forth.
Okay. We know that breast cancer is very common in Malaysia and also in Singapore. What is the best screening regimen that you recommend? Maybe not following the guideline, because a lot of people are worried about mammogram and it may not pick up the real cases. So what's your opinion about it?
Yeah, so I think first thing is most guidelines globally would recommend doing a mammogram once every 2 years when you're 50 years, right? So that's standard out there. But many people may have some family history that may increase their risk. A small proportion of them may harbor mutations like BRCA1 or BRCA2. Then your risk increases a lot. 80% of patients who harbor BRCA2 will get breast cancer at some point in their lifetime, right? So that's why they do prophylactic mastectomy and so on, which is quite radical, but unfortunately, because the risk is so high. So my advice is, if you're 50 and above, get your mammogram. It is still pretty sensitive. Now, of course, an MRI breast may be better, but MRI breast, as you know, is costly. So it's not cost effective in a global scale. One thing to highlight is there's data that suggests that patients who are much, much older in their 70s may not benefit so much from screening. So this is where I want to highlight the concept of ageism. Okay, the thing is, if you are 70 years old and you're fit and you're going to survive more than 10 years, you should still get screened, because you may still get cancer, and with the current treatment, it will enable you to survive cancer-free beyond what, or at least up to the point you're expected to survive. But if you're unfit 70-year-old or even unfit 60-year-old with only an expected survival of 5 to 10 years because you have so many comorbidities, then doing this may not be so useful. So it all depends on your projected survival, your physiological age, right? So that's one point I want to make. Now, if you're younger and with a strong family history, the guidelines would say do a mammogram every year when you're 40 years and above. So that one is because people who get cancer at a younger age have a more aggressive cancer. That's why you need shorter duration between the mammograms. Yeah, if you're 50 and above, 2 years, because you're not going to get a more aggressive type of cancer. So these are some of guideline recommendations. Ultimately, you have to talk to your physician to assess that risk. And like I said, MRI breast is very expensive. So usually the common screening methodologies would be mammogram or ultrasound. Because if you have very dense breast, then mammogram may not be so good. So you need both mammogram and ultrasound sometimes to help with the screening.
Okay, and you mentioned about diet contribution. Can you elaborate more regarding diet and also microbiome? Because I'm sure there's a lot of data that talk about microbiome in terms of prevention and also for treatment, because certain microbiome can enhance or worsen your chemotherapy effect.
So the first question, now diet, as I mentioned earlier, things like smoked food, whether you grill, barbecue and all, increases the risk of gastric cancer. As I told you about smoking and alcohol. Alcohol can increase the risk of hepatocellular carcinomas, cause gastric cancers, not directly, but excessive consumption. That's one problem. There are other things that it's very hard to pinpoint. Now, recently they found artificial sweeteners to be carcinogenic. And every now and then, they will find certain healthcare supplements and products with things that are toxic, that are carcinogenic as well. So usually, I think the food approval agencies like FDA in the US or even in Malaysia and Singapore would review these food products before allowing it to be sold. Unfortunately, there's a lot of illegal things out there as well. So I would caution, when you want to use traditional medicine, be aware of what you're using. Some may make you feel good, may improve your appetite, or may be used for beautification, but they may have carcinogenic chemicals inside. The other thing about diet is obesity. Obesity is linked with many cancers: pancreatic cancer, colorectal cancer. Low dietary fiber is linked with colorectal cancer. Obesity is also linked with breast cancer, prostate cancer. So, by living a healthy lifestyle, trying not to be obese, losing weight, you're actually going to help. Right now, about microbiome. So microbiome is a big topic now. I think we realize that gut flora or microbiome plays a critical role in modulating a lot of metabolic effects in the body, including how some of the cancer drugs work as well. So I treat urological cancers. So in kidney cancer, there's a study, and now it is run across other cancers as well. If you take antibiotics while on immunotherapy, you are actually going to reduce the effect of the immunotherapy, because antibiotics will wipe out your regular gut flora or microbiome. And when it does that, the immunotherapy actually gets modulated. It doesn't work so well. So this is some things people don't think about, because they'll think that, oh, I'm taking antibiotics, so immunotherapy should be okay, shouldn't be much of interaction. The answer is yes, they don't interact, but it impacts how the immunotherapy works. So now there's a phase 3 trial ongoing right now using actually what is this microbiome, actually microbiota, to combine with immunotherapy to treat cancer. Because on the other end of the spectrum, when you don't wipe it out, maybe certain kinds of bacteria can work together with the immunotherapy to enhance your immune system's activity against the cancer. So there are a number of these studies that are ongoing right now. So microbiome is a huge area of interest in cancer care, and we're still learning, but that's as much as I can say right now. Yeah.
And I'm sure that a lot of your patients will meet up with some wellness consultant and also some lifestyle guru. But I'm sure some of these things that they do, like things that change their mood and also their behavior, like meditation or some of these exercises may help them. So do you encourage them to do this, and or do you discourage them from doing that?
I would encourage things that are not things that you don't need to consume. So basically, these are things that they can do, like physical exercise or meditation. Now, yoga, meditation, there are numerous studies that show can modulate your mental state, and by doing so, actually help you with your cancer care as well. So I would say yes, do consider these as supplements to your cancer journey, and not to stop it. So exercise is critical. Additional things like yoga, like Qigong is a form of exercise. I encourage my patients to continue to do these things because it improves their general well-being and mental state. And during your journey with cancer, there'll be good days and very bad days. And some of these things actually help you fight those bad days and overcome those challenges that you face from physical impairment and deficiency. So, for example, fatigue is a big problem, but patients who are regularly exercising overcome fatigue much better. Their metabolic rate improves, their diet improves, and their general well-being is better in multiple surveys. So there are actually now exercise programs looking at this. In fact, it's a big area called cancer rehabilitation. So it's nutrition, it's exercise, it's psychosocial oncology, talking to people, forming support groups. Talking about cancer actually makes people feel better as well, especially if it's among fellow cancer sufferers. So there's so many of these things that are definitely beneficial, and there's science to support as well. So to answer your question, the answer is yes. But anything that you eat or consume, be careful because of interaction. Because many of the oral drugs we give in cancer actually are inhibitors or inducers of hepatic enzymes. So when that is the case, whatever drug that you take that are also inhibitors or inducers may either reduce the impact of the cancer drug or increase the toxicity. So you need to be very, very careful about that.
Okay, there's a question from Dr. Rajeswaran. He knows that you are an expert in urologic cancer. He said, is there any way to prevent cancer of the prostate? But before you answer, I also want to highlight to you that I'm a promoter for whole food plant-based diet. And I always say that anything that contains a lot of hormones like the eggs and dairy products are very bad for our sex organ, which is the breast and also prostate, for prevention of cancer. So can you tell us your view about this?
Yeah, so I can't comment on the nutritional part of it. What I can say is obesity definitely causes it. So eating very high saturated fats, and that actually is hidden in a lot of processed food, right? So people may not think so much about it when they eat their nuggets or their French fries or their luncheon meat, but all these are processed food with high saturated fats. So this is probably the opposite spectrum to your whole food, right? So these are the processed food. So consumption of that leading to obesity increases the risk of breast and prostate cancers. Now, with regards to hormones in chicken, and obviously they give this to cows and all that in order to produce more milk. I can't really comment so much. I'm not so familiar with the linkage between that and cancer. So specifically in prostate cancer, what we advise is, I tell my patients the same advice cardiologists give you. Cut down saturated fats, don't eat too much simple sugars, reduce your weight, do exercise. So exactly the same advice a cardiologist gives you is what I would give my prostate cancer patients, and even anyone who wants to prevent prostate cancer. Unfortunately, in spite of doing all of this, many people, men above the age of 70 years old, will get prostate cancer. It's just the way it is now. 80 to 90% of them will have actually a slow growing type. You'll never find out until after you die. Also, they do post-mortem, then only they may find out. But it wouldn't cause death, right? Many of them still die from cardiovascular illness, other things. But about 10% will give a more aggressive cancer, and they are the ones that we need to pick up early and treat accordingly.
Okay. At the moment, there's about 141 live audience, and you mentioned about some of this drug may have interaction. So because there are so many of this therapy that's new and also unfamiliar to us, you said antibiotic is not good for immunotherapy. Is there any other drug specifically? You said about hepatic enhancer and also reducer. But what are the name of this common drug that is, we have to think properly before we prescribe?
Okay, I'll give you broad categories. So firstly, antifungals, okay, antifungals, antibiotics, certain antibiotics. So because these are things that as a GP you'll be giving out. So when you're giving this out and you know as a cancer patient, please check with your lexicon or one of your pharmacy directories. Then you just type in your drug, whatever antibiotic you're going to give, or antifungal you're going to give, or anticoagulant, you're going to give, and put in the cancer drug name and look for interaction, because you may find that there could be interaction with the cytochrome P450, either as an inducer or inhibitor, and that can cause this problem. The other large group is anti-epileptics. Anti-epileptics are also in this category where you need to look for interaction. So that usually, I think GPs don't give so much, usually in neurologists. But for GPs, please be aware about your antibiotics, antifungal that you give. Oral, the topicals, don't worry so much, the absorption is minimal. But oral, please keep in mind. For cardiologists, there's some of cancer drugs that cause prolonged QT. but usually the interaction is also with, like, for example, antifungal and certain targeted treatment that may cause this as well.
Okay. Okay, I have a final question for you. So many of these therapy that you mentioned, what are the price ranges and if you consider the environment in Malaysia, how much of this is covered by the public sector and also by the insurance in the private?
So I'm quite familiar with the coverage. There's something called a blue book in government hospitals. Unfortunately, a lot of these therapies are very expensive, so most of them don't get into the blue book, so it's out-of-pocket cost. Now, insurers do cover in Malaysia, so depending on usually insurers do not really go very much into the indication per se, because they have coverage limits. So if you cover, I mean, if your cost exceeds the limit, then you have to pay. Now, big picture, chemotherapy, very cheap, because most of them are generic, so you don't have to use original. So there are 5-FU, cisplatin. These are very common chemotherapy. Paclitaxel, few $100s. Targeted therapy, a range anywhere between 5,000 ringgit to 20,000 ringgit per month. Targeted therapies. So usually insurer will cover. Some of it are in the blue book, the older drugs, and some of it in prostate cancer can become generic. There's a drug called abiraterone. Last time was about 20,000 ringgit. Now it's just about 1,000 ringgit. So because they're made in India now, the patent life has expired. Yeah. Now immunotherapy is about 30,000 ringgit for the full doses. So anywhere between 20 to 30,000 ringgit per month. So that's still a big challenge for most people, to afford 30,000 ringgit of treatment every month. Insurers usually will cover up to whatever limit that you have. Unfortunately, not covered by the government, so it's a costly treatment. Yeah.
Okay. Okay, I think we have answered a lot of questions that we posed to you, and thank you for your time. And there are about 144 participants who are watching this at the moment, and this is recorded and you'll be uploaded about 1 or 2 weeks later. So with that, I will stop here and thank Ravi for helping us and also giving us all this information.
Thank you. Thank you.
Thank you.